Okay, good morning everyone, and thank you so much for deciding this morning to join a discussion by the Palliative Care Association of Uganda. You are all welcome. Just to remind you that this discussion is for the Palliative Care Fraternity. Okay, good morning everyone, and thank you so much for deciding this morning to join a discussion by the Palliative Care Association of Uganda. You are all welcome. Just to remind you that this discussion is for the Palliative Care Fraternity. Okay, good morning everyone, and thank you so much for deciding this morning to join a discussion by the Palliative Care Association of Uganda. You are all welcome. Just to remind you that this discussion is for the Palliative Care Fraternity, the Palliative Care Association of Uganda. You are all welcome. Just to remind you that this discussion is for the Palliative Care Fraternity in our country, in Uganda, and we tend to admit everybody who comes online, but we the Palliative Care Association of Uganda, you can sign in to become members, and I think the team is going to display some of the information on how you can become a member. It is quite easy, especially if you are involved in offering palliative care. We would like you to be a member such that we admit you, and whenever we have you come to this meeting, you come on this meeting as a member of PCAU. And those who may not have renewed their membership, we request that you do so. You renew your membership, and the same procedure can be followed. There will be a banner or a flyer to show you how you can sign in to become a member of PCAU and how you can even contribute to our work as time goes on. We have a brief agenda for this meeting, but we are supposed to have a very fruitful discussion. We are going to pray as we I'll give you a highlight of who will present, and then after that, we will have our first presentation, and I hope Dr. M is online. After our first presentation, the second and the third, and then we hope to have some time of questions. So everybody in women or professionals, kindly let us pray. Dear Lord, we thank you so much for the opportunity of a meeting and for technology. We ask that you be with us in today's meeting, and that whatever we discuss should be beneficial. We're able to use these gadgets, but to the patients and their families who are across the country in this challenging time. Thank you, Lord. In your name we pray. Amen. Amen. So my name is Mark Donald Mwesiga. I am the leader. I'll be hosting this meeting, and we have a great panel. We have Dr. Jackson Orem, who is the Executive Director of the Uganda Cancer Institute, which is the premier cancer institute in our country, and they are mandated to offer all the cancer services and to offer the policy direction for cancer care in our country. We also have Dr. Samuel Guma, who is the board chair of the Uganda Cancer Society, which is an umbrella organization bringing together all organizations involved in cancer services in this country. Dr. Samuel Guma is also the Executive Director of Kawempe Home Care. We will also listen from Antonia Kamati. Antonia Kamate is a palliative care nurse. She's a nursing officer, hospice in Mbarara in southwestern Uganda. Mobile Hospice Mbarara is a site for Hospice Africa Uganda, and most of you online should be knowing this. Hospice Africa Uganda is the pioneer palliative care offering facility in our country, established by Dr. Anne Merriman, and I hope that we can have that presentation, which will be the last one from Antonia. And after that, we will have a session of questions and answers. We will give Dr. Rem more time to present, and I request we'll give Dr. Rem more time to present, and I request that we all pay attention and listen, and then after, I'll bring on the other presenters. Thank you so much for joining, and I now request Dr. Rem, Dr. Jackson, now request Dr. Rem, Dr. Jackson Rem, the Executive Director of Uganda Cancer Institute, to give us an update, first of all, about what the Uganda Cancer Institute is doing right now, because we are fully aware, like you saw in our message, that the Uganda Cancer Institute is operational. We thank them for all the commitment in this time. We are aware that recently they offered transport to people to go back home, those who were at UCI after getting their treatment. In the same spirit that we ask him to speak to us, because we know that they play an important role in as far as the offering of palliative care services are concerned in this country. I have not repeated the objectives of our engagement because I know that most of the people who are online have been with us. Engagement for every Friday at 11 is to make sure that we, as the Palliative Care Fraternity in this country, remain updated on what is happening. We discuss any challenges that may come up as the country responds to COVID-19 pandemic, and we discuss as the country responds to COVID-19 pandemic, and we discuss solutions, or we make suggestions to what should be done to overcome those challenges. After the call, we as the National Palliative Care Association, we follow up to make sure that we reach all the stakeholders, given the challenges that come up. We follow up to make sure that we reach all the stakeholders, given the challenges that come up. Thank you so much. And Dr. Rem, if you are online, kindly present this gathering. Do we have Dr. Rem online? We seem not to have Dr. Rem online. I'm going to ask the team here to find out. Can somebody make a phone call and let's make sure that we have Dr. Rem online. According to the way my screen is spread, I'm unable to see if he's online. But I'm seeing great people from the Uganda Cancer Institute who are already online. And as we wait for Dr. Rem to come online, I am going to request that we don't wait and spend a minute. I am going to request that we start with a presentation from Dr. Samuel Guma. Dr. Samuel Guma is a medical doctor. He is a public health and palliative care specialist. He is interested in ensuring access to palliative care and pain relief to people who have palliative care needs. Chair of the board of the Uganda Cancer Society and founder and executive director of Kawempe Home Care. I can see Dr. Rem has come online, and forgive us, but I think it is better that he presents first. Dr. Rem, you are most welcome. We need to listen to hear about the updates about what the Uganda Cancer Institute is doing in this period. We have already thanked you and your team for all the great work that you have been doing in this time. And we request you to give us an update, share with us some of the challenges, some of the solutions that you have for this, and you also share with us the plans for the future. And the people who are on the call, who are now 50, are people who are from the entire country. Dr. Rem. Dr. Rem from the entire country. Dr. Rem. Dr. Rem. We are sorting out that people who are speaking, we are just switching off all their microphones, but I request Dr. Rem to be online and to speak to us. Dr. Rem, I have unmuted your microphone. You can hear me. Kindly go. Dr. Rem, I have unmuted your microphone. You can hear me. Kindly go forward.
Yes, I can hear you. I'm uploading my slide. All right. I think we are set. Mark, are you hearing me?
Please go ahead.
Yes. So,
yes, I'm hearing you very well, Dr. Rem. And
good morning, everyone. I want to start by thanking Mark and then the PCAU Fraternity for arranging for me to have an interface with you on the issue of COVID-19, also called severe acute respiratory. And of course, the question is, what are we doing as Uganda Cancer Institute? By extension, what are we doing as a country? This is the image that I think is well known to all of you of how the virus is depicted. It has on its surface some receptors that it uses for getting in touch with the body cells.
Dr. Rem, you are not sharing the presentation.
You are not seeing it?
Yes, kindly share slides. You are sharing the front of your screen. Slides. You are sharing the front of your screen. You just need to share the slides.
Oh, okay. Let me have Mark. Does that make a difference? Hello.
Yes, we can see it.
Now you can now see it.
Yes, we can see it.
Now you can now see it.
Yes, we can see it now.
Thank you.
Yes, we can see it now.
All right. So, yeah, I think you could have seen that the first slides already, and then I was on this one, and then I was on this one to just show you the picture of what the virus is depicted to be looking like. The most important is that it has on its surface some knobs which attaches to receptors on the cells. For any disease, knowing how it affects or how it is distributed in community is very important, and how it affects human beings or the population, and that is called epidemiology. Of course, this disease started around the end of 2019. The first cases were reported in China, I would say officially in January, but by December and probably there was a big problem. Of course, as of April, this is a bit out of date, 19th, world over there were about 2.4 million cases of infection, and the death toll. Now, there are some groups that are at increased risk, and age is actually a very important factor. And then there are other diseases, including cancer, that are actually considered as high-risk conditions. And these are conditions. And these are the people who we should be on the lookout for, because when they get infected, then the outcome is likely to be bad. Age is very important. The elderly people are most adversely affected by this condition. That said, of course, the clinical presentation, the disease presents as a spectrum, but the incubation period is about 14 days, and the median period of 14 days, and the median period is about 4 to 5 days. Precisely, actually, they say about 5.2 days. And then the spectrum of illnesses range from those without any symptoms or asymptomatic cases to those symptoms or asymptomatic cases to those with severe disease or acute respiratory syndrome, and then, of course, it can lead to death. Of course, the best figures that the best figures that we have in as far as the impact of this disease is concerned in our special group, that is the cancer patients, is gleaned from the experience of the Chinese. In summary, by the time the parts of the world, there were about 72,314 persons in China at that time, and 81% of those were mild cases, and then 14 were severe, and about 5% were critical. Of course, all that depends on the population. It's small, but in terms of human beings affected, the numbers are big. And the most common presentation would be cough, fevers, and then shortness of breath. And then, of course, there are other presentation. Not two people may present in the same way. Of course, I think some of you have heard about this loss of sensation of smell, which at times people are thinking that is the sign that somebody is infected, but all those are not fully verified yet. And then in terms of laboratory findings, low blood count or even high blood count tend to be common. And then there are other laboratory abnormality like affecting the function of the liver, and then also indicators like coagulation defect or developing thrombi seems to be also seen. And then in terms of X-ray, the findings are called atypical, but usually you find that there are abnormal glass-like opacities in the lung. When it comes to management, you know very well that there is a lot of discussion, but there is no specific management of this disease. For those who are symptomatic or who are not yet developing symptoms, there is actually nothing that you can do, only to observe the natural history of the disease, kind of winding itself down. And then individuals who need attention are those who actually have moderate illness, as well as those who have severe, and then those who have critical illness. Those who have moderate illness and require intensive care. And a very classic example of how that is important was the Prime Minister of the UK, because for him, he progressed from mild illness to moderate, and they did not take chances immediately. They made waiting to be put under intensive management. So that is how severe. Of course, the question there is about, as far as we are concerned, I doubt whether we have actually moved or seen cases presenting with moderate or even severe illness in Uganda. I think we are very lucky that we haven't reached there. Now, what about the risk factors or the risk group? Again, we can only gain from the experience of the Chinese. And as you see in the table that I've put out there, the most at-risk group are the elderly, ages over 80 years, and then those who have cardiovascular disease or chronic lung disease and diabetes. And then the cancer patient, their risk is about 7.6%. In other words, those who have cancer who can develop severe illness and progress on to fatality is about just 7.6%. Of course, what we can say is that that may actually be an underreporting of some sort, given the fact that cancer patients are usually closely in touch with the healthcare system. It may actually be that touch with the healthcare system. It may actually be that it is that makes them kind of have an advantage over the other group of patients who in most cases actually do not have very close contact with healthcare system like the cancer patients. And I think that is something which we need. Then the therapeutic options, as I stated already, there is no definitive treatment for coronavirus or for COVID-19. All the treatment is actually symptomatic. And a lot of measures are being tried of chloroquine or hydroxychloroquine. Nobody knows where this one falls, whether it is antiviral or it is just a disease symptom modifier. But there is a lot of debate whether it works or it doesn't work. If at all you are to use chloroquine or hydroxychloroquine, then you need to monitor adverse effect. And this is because we are still waiting for substantial trials to kind of definitively tell us whether it works or it doesn't work. So at this point, I think the most patient, and if you're a clinician, you need to be looking out for what they call a prolonged QT interval when you do an ECG. And then, of course, there are other immune modifier, like the hyperhemoglobin that is usually harvested from undergoing test. There are a lot of centers, especially in America, that are now testing the effectiveness of these. Of course, the question here is whether we in Uganda are in a position to harvest convalescent plasma, and whether we are in a position to the preparedness proper. And our response as Uganda, from the Uganda Cancer Institute, what we did immediately when the pandemic was announced, we constituted an institutional preparedness team of this virus among our community. And our community are the cancer patients and then the caregivers. The team developed a framework based on current available knowledge and guidelines to come up with 4 principal areas of focus, namely general protection of staff and patients, our functions. Number 3, streamlining COVID-19 detection and triage. Number 4, management of information flow. And this actually, we kind of put it up in an outline of services. And the main objective services, and the main objective of doing all these is to make sure that both our staff and our patients, especially when they're presenting with the symptoms that may be common, are quickly recognized, and then we avoid complication. Especially, you know very well that cancer patients may also present with very similar symptoms to those of COVID, for instance, fever, or even respiratory symptoms. If there is metastasis to the lung, the patient may present in that way. So it is very patient as well as a COVID patient. And of course, although, as I showed you earlier, most of the patients may not come with symptoms, our main focus should be getting patients who will fall within the 20% with either moderate to severe, isolate them so that they are managed effectively. That is actually the key thing. And then, of course, we need to protect our staff. The protection of our staff is very, very important. As you know, a substantial number of healthcare workers in Italy, and even now in the UK, actually, health workers are being affected grossly. And of course, we had to reorganize our service, and the objective of this was to make availability of essential cancer care service to be there, and then to improve care service to be there, and then to improve the efficiency of delivery during this crisis. So what we had to do was to put in place stringent measures to make sure that our operations are in line with our institutional guidelines and the basic with our institutional guidelines and the basic principles for controlling the infection of COVID-19. And as a result of that, we suspended some of what we would call elective procedures, for instance, cancer screening, and then our outreach services, screening, and then our outreach services, because those activities can put our staff at risk of acquiring this infection. So those have actually been halted with the aim of avoiding crowding and exposure to COVID-19. And of course, even elective surgery, and of course, even elective surgery and procedures we had to suspend. And of course, given that time has elapsed now, those are things that in the next few weeks, they're going to come up for review so that we can see how we can reintroduce them. Of course, our aim was to ensure that ongoing critical cancer care service are not interrupted, and also the flow of patients in accordance with the plan of that treatment, which we had actually already come up with. This table really summarizes the 4 areas or categories of, I would say, patients who are being referred to the Institute with new diagnosis of cancers. Those ones, we want them to continue coming. And up to today, we are still receiving newly diagnosed patients. There is no reason why a patient who is newly diagnosed with cancer should sit at home and then the disease. Patients who are receiving active treatment for cancer, they should actually come so that their treatment is not interfered with, because those treatments are planned and we do not want to give their cancer disease a chance. And then number 3, patients who have already completed their cancer treatment and are currently on follow-up. Those ones, we want to tell them to stay at home. And actually, I have good news. We are trying to find out how to kind of continue interfacing with this category of patients, either by telephone or those who have access to online resources by online interface. We are working on that already. And then, of course, patients who have completed their cancer treatment on long-term follow-up, those ones, we want them to stay at home unless they have urgent complication. And then, of course, the objective of streamlining our cancer detection and triage is very obvious. As I stated earlier, we do not want people who have this infection, to kind of mix with our patients. So at our entry point, we have established screening points, and if you come to the UCI, you are going to be subjected to screening. And then, of course, we also would want to kind of pick any disease as quickly as possible. And we want even the referral mechanism to be coordinated so that everything is done now. Ministry of Health gives us as guideline for management of COVID. And then, of course, also information flow is very important. There has been a lot of questions being asked by our patients about what to do. And for that matter, what we have done is we have opened a toll-free line. And there are staff of the Institute that are on standby 24/7 to receive complaints from our patients or if they need help. Of course, the next step that we are seeing as we begin to understand the patient even more. I told you about the screening measures that we have put in place. Those screening measures are just to kind of suspect whether somebody has symptoms or doesn't have symptoms or has signs, which points towards COVID. But we want to have in place actually test for detecting the COVID itself. And at this point, we are working on having in place a PCR-based testing here at the UCI. And then we are also going to follow that with having antibody testing capability also here at the UCI. The capability also here at the UCI. The second step that we want to take, and here we want also you to cooperate with us, is to develop a registry for cancer patients who will turn positive for COVID-19, because we want to understand the impact of cancer on this category of patients, or the impact of cancer on this category of patients, or the impact of COVID on their cancer disease. And then, of course, the other issue which is very important is there is need for improved cancer diagnosis, so that we do not lose our patients to either COVID or to other things, just simply because of the situation. Another reason why improved diagnosis is very important, as I informed you earlier, cancer patients are also at risk. They are high risk category. So that means knowing that somebody has cancer already helps in order to improve on avoidance of acquisition of the disease or development of complication later. Then, of course, there is need for us to improve further our infection control. Cancer patients already are prepared in a way, because infection control is part and parcel of the management. That could actually be the reason why maybe we are not seeing that many numbers as such. In other words, those measures tend to insulate also other infections. Another issue which is very important, and I would want also to kind of hear a discussion around it, is better coordination of all cancer care services. We are advocating that this is actually something that needs to be looked at very critically. And then, of course, given that, this is not the Uganda Cancer Institute alone, this is not the government alone, there is need for us to work together. One thing which I haven't seen very much is a statement on this issue from the Cancer Fraternity. I think this is something which is needed. Why is it very important? As I stated earlier, we all know that vulnerability of cancer patients and survivors as a special risk population cannot be overstated or understated. Of course, within this we have people who are undergoing active treatment, but I can also assure you that the adage that once a cancer patient, always a cancer patient, for a cancer treatment, you will never remain the same. So that means you are always at risk. So there is every reason for us to kind of look at both cancer patients and also the survivors. We need actually to make sure that they are put at the forefront for attention or to be placed on a stronger policy to protect cancer care service in this country. I want to borrow a leaf from the UK. As you can see, everything is being done to protect the National Health Service. Don't do that, then that means actually the outcome of whoever is going to be getting any disease is going to be very, very poor. In the case of cancer in Uganda, for the Cancer Fraternity, I think the protection of the Uganda Cancer Institute is very, very paramount. If there is a time that you need very paramount, if there is a time that you need to protect the Uganda Cancer Institute, it is now. And it is from a policy perspective that this is needed. We want to see more civil society rallying behind the Uganda Cancer Institute. In the past, I have to say this very clearly, Cancer Institute. In the past, I have to say this very clearly. When things go wrong, people kind of shy away from the Uganda Cancer Institute. They even blame it. They want to tear it down. I think the example of COVID-19 is actually a real reawakening that the Uganda Cancer Institute is very important, is very key, is very central in as far as management of cancer in this country is concerned. So if there is any policy environment that undermines this, it undermines the whole environment that undermines this. It undermines the whole enterprise of cancer care in the country. I would want to hear also response in as far as this is concerned. And then the other important thing is advocacy for critical healthcare service, such as intensive care, rolled out in the country. We want specifically there should be actually reserved capacity for the care of cancer patients who will develop complications. So in conclusion, I want to say 3 points. Number one is that we need to understand the impact of COVID-19, that then we can actually respond appropriately, both as a government, as well as civil society, as well as survivors of cancer. And then number two, that there is need for us to coordinate our response as stakeholders in a better. There is need for us to have clear policy positions with the aim of protecting our patients, protecting our care workers, and protecting our system. I'll end with that and invite questions.
Okay, thank you so much, Dr. Orem. And we are going to have questions. Everybody, and you can keep your questions. I'm now going to request Dr. Samuel Guma from the Uganda Cancer Society, and I think Dr. Rem has already raised some key important points that we need to. Work together on this, and we are very grateful to what the Uganda Cancer Society has put in place, and to find that even amidst the challenges, we have great plans for everything that is coming on. And so from the perspective of the civil society as the Uganda Cancer Society, and from the perspective perhaps of somebody who is looking at policy and the direction that this country is taking and the patients that are from the Uganda Cancer Society, and what are the challenges, what are the lessons, how can we inform the policy at Uganda Cancer Institute to make sure that it is all embracing. You are welcome, Dr. Guma.
Yeah, thank you very much, Mark. Good morning, everybody. Thank you all for joining this seminar and for this very important discussion about COVID-19 and the impact that it's having on the care for cancer patients. I would like to also thank you all for the work that you're doing. I know very many of us on this forum are involved in cancer care, as health workers, and also into palliative care. COVID-19 as health workers, and also into palliative care. COVID-19 has really brought a lot of challenges to our community, and we at the Uganda Cancer Society, we are really concerned about what's happening. And in line with our role, which is really coordinating civil society efforts for a systematic response to the cancer control, we've realized that coming of COVID-19 has brought so many challenges to cancer care and control in this country. One of the major concerns that we have is really there seems to be a very big problem in terms of access to care right now. And this access to care could be physical and also financial. From a physical point of view, we know what the government has actually put in place really to help control the COVID-19, and that has been mainly the restrictions on movement. We had an initial ban on transports for public vehicles, and then a ban on private vehicles also. And that has actually caused a lot of challenges. We at the society have got numerous to UCI for treatment. We've also got patients who have been stuck here in Kampala at UCI or within the patient hostels and have not been able to travel back to their homes following the completion of their treatment. And this has really brought a lot of challenges, especially for those who were on appointment and needed to come for their treatment, either for chemotherapy or for radiotherapy. The Uganda Society, of course, one of our key roles in terms of policy is advocacy. And when we heard about this problem, we had a lot of discussions with the leadership at UCI, with Dr. Orem, and we kind of forged a way forward, also from the point of view for society. Since we knew that now this problem is really going to affect our society, care for patients and would actually increase on the mortality, we decided to launch a media campaign to create awareness about the troubles that patients are going through. And I believe most of you have seen the press releases that we have put on email, on WhatsApp, and also the TV presentations on email, on WhatsApp, and also the TV presentations which have been shown of the experiences of patients, both who are receiving care at the Uganda Cancer Institute and also the patient hospital. I'd like to really acknowledge that this awareness that we created has led the government to make some changes in their policy. And they realize that there's need for patients to continue accessing care, not only patients with cancer, but patients with other chronic illnesses like hypertension and diabetes. And as we all know, the policy on transport kind of changed, and they're now a little bit more flexible for movement of patients who have got cancer and other chronic illnesses to and from their centers where they can get their care. And of course, they insist that patients, as evidence that they're actually going to seek care and not moving around for something else. So that has been what we've done at the Cancer Society in terms of really trying to mitigate some of these challenges that COVID-19 has really brought. Now, back onto transport, there's still a lot of problems with transport, and especially from the point of view for the health provider. Many of our officers and other care providers who are involved in palliative care and cancer care, our staff are still having a lot of trouble getting to work. And this is because of the inavailability of vehicle stickers. The government actually really came out and said that health services are critical service and these services should continue. But we've really had a service and these services should continue. But we've really had a lot of challenges in getting stickers for vehicles. Many organizations have to use their own cars to go around picking critical stuff to come and provide care. And that is actually kind of reduced on the amount of services that we're able to provide. This is actually happening in many palliative care centers we're able to provide. This is actually happening in many palliative care centers, and I believe also at UCI. I don't think all the staff are being able to get to work and provide services for the patient. This is really not good, because in terms of access, somebody can struggle and get to a facility, but to get there, you go to the lab and there's no laboratory technician to provide the service. And as a society, that's something we're going to continue advocating to the Ministry of Health and the government to really provide more stickers for vehicles to move around to enable services to go on for patients. And in this era of COVID-19, we're really advocating and insisting in terms of the policymakers that cancer care must go on, actually go through the entire course and have a chance to a better life and improved quality. So we're really going to be insisting on that point as we go along. We also have patient hostels within and around Kampala, where patients are kept, patients with cancer, and these patients are really brought to the Uganda Cancer Institute. Again, transport has been a big problem. The Palliative Care Association of Uganda has actually done a good job in actually supporting many organizations to get speakers so they can be able to continue their work. And this is something we're going to continue advocating for, and we call upon all of you to keep on raising that matter and for. Then the other important issue is the fear of COVID infection by health workers. The fear of COVID infection by health workers, and this is important. And it has already been mentioned that PPE is very important. I think the leadership of organizations need to put in place the necessary PPE so that staff can really be comfortable and go to work and know that they are protected against this COVID-19. Other challenges of of course, for those involved in care is increasing prices. The hostels have had a really big challenge right now. Food prices have been increased due to the transport restrictions. That's also affecting the care that is being provided to the patients. Yeah. So in terms of challenges, that is really what I wanted to put forward about the impact of COVID-19 on cancer care. Now, to talk a bit more on the palliative care fronts, I think it's really important for all palliative care professionals to realize that our role is really very important at this point in time. Pain and symptom control is really, really important right now. We cannot hold our services because we ensure that our clients, especially who are on pain treatment, those who are morphine, are able to access it. And I would like to thank all those who are involved in this care for all the different kind of innovations that have been put in place to ensure that patients get access to the pain medication that they need. And we encourage everybody to go on receive care either at the centers, basically outpatient care, or home-based services. Home-based care has been affected very much right now with this transport restriction. And again, this is something we're going to continue advocating to the Ministry of Health to give us more speakers so that we can really be there to reach out to our patients who are hard to reach, out to our patients who are hard to reach or who are at home who need this really very important care. The pain and symptom control right now should be highly emphasized, and we should not let anybody suffer with pain because of this COVID-19 period. So in conclusion, the Uganda Cancer Society is really aware of the challenges which are being faced right now by patients with cancer. And this is a time when we're going to really scale up our advocacy efforts, all fronts, policymakers in government, and the Ministry of Health, and others, to ensure that the patients get access to care and they get the services that they really need. I thank you very much for listening to me, and they get the services that they really need. I thank you very much for listening to me, and I'm happy to receive any questions. Thank you.
Guma, and I switched on my video to remind you about the time, and I'm glad that you came to a stop, and we still have some time to stop, and we still have some time to listen to someone else. And Dr. Rem raised important questions or important points that maybe the Uganda Cancer Society you can note down, and maybe as we conclude you will respond to. And of course the toll-free line is important, and maybe as we conclude you will respond to. And of course the toll-free line is important for all the palliative care providers in this country. If this toll-free line is already established, we will be glad to have it. The important fact and an infection for the cancer patients, wherever it's something that you can speak about. How are you as providers, cancer society? And the other important thing about working together for any cancer patient that gets this COVID-19, and it's also all the other key points that Dr. Rem mentioned, that you can also about the mobility of patients, the transport, the hostels and everything. And I know the President has made a directive about this, and the Ministry of Health is working towards that. Dr. Amoni online, maybe he will respond after that. But right now, I want us to receive a presentation from giving us a community perspective. What is happening at the community? We have service providers who are interacting with patients daily up country, and we identified Hospice Africa. They are seeing the most of the palliative care patients as a civil society organization, as the pioneer hospice in this country. And we request Antonia, if you're online, to take it on. Keeping your time. Tell us how you are working hand in hand with government and how you are reaching out to patients, and you have presented. Give us your experience, and maybe some other palliative care organizations can learn from you. And give us your message for the Uganda Cancer Institute, because you refer patients to them, and when patients are discharged, they normally go to you and you reach them in homes.
Thank you, Mark. Good morning, everyone. Dr. Rema, listeners, and our dear host, Mark, good morning. I want to also use this opportunity to thank everyone for the work they are doing during this time of the COVID lockdown. I really appreciate people are really struggling to continue providing service despite the many setbacks. But I think people are really being heroes in their small settings. Thank you very much. I am the site programs manager at Mobile Hospice Mbarara, which is found in southwestern Uganda. Going to our topic today about how cancer services are being provided in this time. We as Mobile Hospice Mbarara provide palliative care. And palliative care simply means care given to people with life-threatening illnesses that may not respond to curative medicine. And the focus of our illnesses that may not respond to curative medicine. And the focus of our palliative care is really quality of life through pain and symptom relief for the patients and the family. So we are situated in Mbarara municipality, but we provide service. Mostly for the rural community and in the southwestern part of Uganda. So we find ourselves taking care of patients who come from Mbarara, Ntungamo, Rukunjiri, Kabale, Kisoro, Shema, Bushenyi, Rubirizi, and even Kasese. Patients with cancer, many of them on our program have severe pain. and they need a really good painkiller. Thanks to Ministry of Health, there is morphine, oral liquid morphine for taking orally to us through Ministry of Health, National Medical Stores, and GMS. We are able to have it with us. Maybe for the benefit of the listeners, actually, Hospice Africa Uganda is the one that produces this morphine, and then we submit it to National Medical Stores and the different organizations that supply it to the people, to the health facilities. So severe pain is something we have to face in the community. People with cancer have severe pain and they need morphine. And as I said earlier, palliative care is about pain and symptom control, and it's very have morphine at their disposal. Otherwise, it's a very frustrating place to be. Morphine is not everything. We also have other ways we try to control pain depending on the level of pain. And palliative care is also about holistic care. For example, we look at not at social pain, we look at psychological and spiritual pains of these people. And ideally, that's what palliative care is all about. It's not only looking at the physical condition of our patients. We try to look at them in their totality and in their everything they need. Now, we've really been challenged because we had to reduce to scale down on our activities. We don't do outreaches anymore. We don't do home visits as often as we used to. We really had to scale down our services, and to have, say, like around Ishaka Hospital was gracious enough to give us space. So we would go there once a month to see patients who come from that side, Bushenyi, Kasese, Rubirizi, that side of Uganda, to cut on their transport needs from there where they come from to Mbarara. But that now has stopped. So all those patients are struggling. Then we also had another outreach in another side called Isinjiro, where we would help people who would stage within the town. Some private practitioner was gracious to give us her clinic, and we would see patients from there, go along the road to give us her clinic, and we would see patients from there, go along the road to another health center called Shunjezi and another one called Chikagati near the Tanzania border. But also there we do not go. So what am I trying to paint? I'm trying to paint a picture of all these people who are unable to paint. I'm trying to paint a picture of all these people who are unable to come because the finances are too much for them. So we are wondering what is happening to such people. So that has really been our experience. So we focus on outpatient. We work closely with Mbarara Regional Referral Hospital, where we need to add patients probably for blood transfusion, cancer screening and staging. We provide a service of testing the biopsies, especially for the very poor who cannot pay the 70,000 for a biopsy to be analyzed. And then we help them to go to Mulago for radiotherapy. But that's another area where those we managed to send to Mulago had to come quickly back home before they were locked down in Kampala for COVID. Now we are faced with a situation where women are calling us and they are bleeding in the village, and we have to find out getting them to the hospital for blood transfusion. But can they come for radiotherapy? It's crazy. On that, officer at Mbarara and his team were really supportive. Were able, through their support, to get permission from the RDC for 2 of our organizational vehicles to be able to move around a bit, which was really, really a plus. And that was good. And also, we sit down, we see patients from 8 to 5 from Monday to Saturday. Because we're in a rural setting, we actually walk to work. We don't have that challenge. We walk to work. Only around 2 staff members have to be picked from home. And on a daily basis, we see from 11 to 18 patients who come. We get like 5 to 8 phone calls every day. And we have been in a situation where we had to do some emergency home visits. So we feel that is a success because we're able still to provide the service despite our situation. And of course, when we go home, we use personal protective equipment. And of course, when we go home, we use personal protective equipment as much as we have available in our means. We wash our hands, we protect the family and ourselves, but at least we're able to reach out to these people and help them. Actually, there was one lady who really needed a catheter change, but we made it. We went there and helped her out. So we really needed a catheter change, but we made it. We went there and helped her out. So the needs of patients, our palliative patients, are real, but this whole COVID situation makes it difficult. So most patients, when we go to challenges, most patients are struggling to find means to come for their medication, They either send friends or family members, or some have braved the walk and walked kilometers and kilometers and reached at hospice, and they look like they are going to die. So it's really hard also for us to see those things happening. So they say the friends may come by bicycle, they may have enough money to send a border, which is also not cheap. Some have to walk up to the health facility, but then they need to contribute towards the fuel of the ambulance and they can't afford, so they just go back home. And they call us and tell us these challenges. It's really in the community. And then, of course, the staff members are also, like I had Dr. Guma mention, they're afraid of the COVID infection themselves. How do they protect themselves? So we have tried to make our own gowns and masks, hoping it will be enough to protect the team, but it is a good thing. And other health providers like ourselves when they are distributing the protective gear. So it's really like that up here in the community. We are struggling like everyone else, and we are doing our best to see how we can continue to provide the service. And maybe as I conclude, noting that our service of palliative care is unique. It focuses on quality of life, but we are struggling financially, at least us at hospice. And to be able to maintain our service in the form it was designed to be given is really becoming hard, with all this COVID making it difficult to get the finances we need. So if we can somehow get support also from Ministry of Health for palliative care, that would be really, really a plus. I thank everyone for paying attention to me and for participating. I welcome all questions, and I believe other team members from hospice can also join in and help me answer the questions you need to be answered. Thank you so much, Mark.
Thank you so much, Antonia, and for sharing with us. I think you speak like somebody really at the community level, and for sharing with us. I think you speak like somebody really at the community level, and of course, amidst all these challenges, even when you mention about the difficulties in transport and everything, I think you have very well with the district health officer in your region. You are working very well with the regional referrals, and you are also able to move and even do home. Even enough, you are seeing a number of patients. You are seeing an average of 18 to 25, which is something very good that we should commend you for. And you can also, or we can talk about using borders more. These were our presenters this morning, and I now want to open up for questions. We have 20 minutes and down, and of course I had already mentioned some of them. And one of them is to Dr. Rem, and asking, I pick the name, I wrote it down, but it's online. What is happening to the decentralized cancer services? Do we still have cancer services up country? And this is to Dr. Rem, and I'm sure he's able to answer that. And it's the same if the decentralized cancer, he's able to answer that. And it's the same if the decentralized cancer services are down, can people are they able to call in on phone, and are they able to be visited? I think this is the same question. And the other question that is going to Dr. Rem, you talked about patients and how they are coming. Some of the patients are really worried, and these are cancer patients. Does any plan for psychosocial to patients, especially those who are treated, and the last said that once a cancer patient always again COVID-19. I think you answered that in some extent, but you can respond to it. And the last one on the call, we have Dr. Rem respond, and then we can have Dr. Kumar respond, and then any questions in the chat box. Dr. Rem.
Thank you very much, Mark. I must say that some of the questions, because of the system, were not very clear, but I'll respond as much as possible how I understood them. About what is happening to the decentralized services. What is happening to the decentralized services? Of course, the service like in Barara is actually going on. Patients are still getting their treatment. And then the rest of the other places like Arua, etc., we had not yet kind of like Arua, etc., we had not yet kind of fully, I would say, operationalized those services. So that means those patients can get in touch with us. And the toll-free number I can see has already been provided, but I can read it. You'll see the toll-free number from the UCI is 0800-100-800. So that number is available. The plan for psychosocial support within the Uganda Cancer, something is being done. And I'm happy to see that Dr. Mwebesa is the forum here, is actually our consultant, trying to come up with a plan which we are going to be using, not only for psychosocial support, but within that, we are going also to have, we want to have a very strong psycho-oncology service. I think there was another question which I did not get clearly around the once a cancer patient, always a cancer patient, and what is being done. I don't know what the specific question was, but the point I was trying to make there is that after going through a cancer diagnosis and cancer management, your body will not return to what it used to be before. That means there may be some defect in terms of immunity that will always live with you, and that will put you at risk for either developing a second malignancy or contracting infection, and we should not take chance. We need to guard against. So that was the point I was trying to make. I hope I got the question anyway.
Yes, and the question was saying, what do you advise on how should they protect themselves from COVID-19, people who are leaving UCI? And I think you answered it in your introduction remarks when you talked about prevention. Mwebesa, I can see your hand, and I think you wanted to say something quickly. If you can say it, even since your name has come up. Dr. Eddie?
Yes.
Go on.
Good afternoon, everyone. Thank you for organizing. I think that's teaching us a lot of things. How surveillance of lives and,
You have to hold the button down, Eddie.
Offer services to
okay, I can't hear.
Better services abroad.
Unfortunately, yes. I can't hear you, Dr. Eddie. I'm going to request that we mute him for some. Also see a question from Stanley. Somebody called Stanley Ejoy. Is your question going to UCI? Kindly mention it if it's going to UCI.
Sure. Dr. Amanda is online. You could guide on that.
Dr. Amandwa, you are online. Please ask your question.
Yes, thanks very much for the discussion. I just on the brilliant which have been one. I think we need to clarify on patients who were being treated abroad. How is the UCI going to address them? I think that's an area in which we need to work. But number two, I was thinking, where do we put strategically palliative care in this response to the COVID? The already of patients who relatives who need psychological support. And the nutrition area we need to focus on. Number 3, I think we need to see how the medicine can be delivered, especially pain medications. Actually, especially pain medications. Actually, I have been arranging UCI and they have been giving us for some of the patients whom I know. I think that should be internalized through the national passport. And I'm glad to say that actually the district teams and the minute of them that the minute of them that are responsive. So if the cancer and Palliative Care Fraternity could be part of the national task force, especially for transport, I think this will ease our situation greatly. And lastly, I'm concerned about the staff who are working in all this. And if they are testing facilities which come, actually they should be the first. I was in the UCI to see a patient last time. There's still a lot of help we need to get for the staff. We don't want any of our staff to be infected during this time. Lastly, this lockdown really think of how we can rearrange home care through the district and national corona task forces. Because here in Kaweme, where I stay, it's extremely difficult. But the good thing is the transport committee is responsible to treating most patients. So we should take advantage of that. I would like to request that Mark, Dr. Rem, and Dr. Moniz will take it up. Then we can give them the relevant support. This is to pick the patients who need from the community and return to pick the patients who need from the community and return them. And then this can be done through the transport committees and the RDC. Thank you very much for the very, very good meeting. Thank you very much.
Thank you so much, Dr. Mandwa. And I didn't know you were online. You are a proxy somewhere through someone else. Do we have any other question? Because I think Dr. Rem is answering very well on chat box, and maybe the only question that he will answer after everybody has spoken can be about patients who have been getting treatment from abroad. Do we have anybody else raising up their hand? I don't see.
I would like to say something. I'm using Diana's PC.
Kindly introduce yourself. I didn't pick you. Who is this?
Okay, my name is Rose Kiwanka. I'm in the community, and I was very happy to hear that Dr. Orem say that once a cancer patient, always a cancer patient. You don't remain the same, but that's not an issue. I want to say what I'm observing here in the community. Being that I'm in the village here, I can see that the local leaders are really at the forefront in this time of COVID. They are being called upon, but then they don't have enough knowledge about COVID. And they are going in, trying to help the patients. I've seen some of them drive their own cars to take patients to hospital. And my concern, these people are not protected. They do not have enough knowledge. So if there is people are not protected, they do not have enough knowledge. So if there is any problem, they could again be a danger to the society. Therefore, I think we need to help them. How we do it is still a question. I'm struggling with it down here because of the standing operation procedures that are put in place. Don't bring people together and the like. Because I was thinking that we need to sensitize them so that they know how they can help, but they need to protect the issue of coordination. Really working well. If we have people at the grassroots like these LOCs and we work with them, they can have people in the community to identify these patients, and then we link up with either Uganda Cancer Institute and Mobile Hospice in Bara, whatever it is, I mean those services. So we need to look at the local councils in our places, empower them, work with them. They can be very good at coordinating, helping us to coordinate services. like Dr. Orem said that then they follow up with phones, the same thing with hospice. Some of those people may not be able maybe to phone back or whatever, they may have challenges, but the LOCs, if there is a network, they will be able to do that service. Thank you, Mark, for giving me the opportunity, and thank you so much for organizing this formative.
Thank you so much, Rose. And so the other question, which should be quick, is from Michael Boa. Michael Boa, I see your hand. I think this is a journalist. Michael Boa, kindly introduce yourself properly and tell us who you are, and then you can ask your question.
Yes, thank you so much. My name is Mark, a digital marketer, and I'm supporting this presentation or this online meeting online via Twitter. So, in other words, I'm tweeting what is happening here to the world to see. So I wanted Antonia to share some pictures of the gowns they've made. Antonia to share some pictures of the gowns they've made. Because if we share what they've done, I think the Ministry of Health will come through with some help, because we've got quite a number of donations of PPEs. And I think they can give us some to the nations of PPEs, and I think they can give us some to them to those who need here. So Antonia, if you have some pictures of the gowns you've made, and probably of people wearing them, they will be very nice on media.
Thank you so much.
Thank you, Michael. May I say something, Mark?
I'll
Hello?
give you an opportunity to wrap up, all of you at once. We have 7 minutes to conclude, just to check in case there's anybody else who has a question. And I don't see anybody. This is Fred. Fred, do you have any question? I see your hand. Somebody called Fred Mwevia. Quickly, 6 seconds.
Yeah, so mine is not a question. Mine is just to commend the work you're doing, and also to ask the team that this period is very, very crucial for information to be put out there. So, Mark, I'm asking that every person that is part of this video from their community, from their institution, to join the social media teams and be sending out as much communication as they can. It is very, very key, and information is what people are rallying on now to get everything they need. So I commend you for the job well done, but please set up and make sure that people are informed about what is happening here.
Thank you so much. And I think Fred is also part of the, many other people, journalists, and so he's talking about information just as like Michael. And we are doing, this is what we are doing. We are bringing you first-hand information from the people who are doing safe and people who are committed to ensuring that services reach everybody in this country. And this is one way of making sure that information is shared. And if you are in the media and you are part of this, first of all, we ask you to share credible information. You can reach out to people who have spoken. You can reach out to me, and I'll very gladly connect you to make sure that what you are sharing out to the public is what is important. The same with the message from Rose about reaching out to the community, and even working with community health workers who have been very, very important in this season. We need health workers who have been very, very important in this season. We need to see how best we empower them with information such that it reaches down to the people. We are now at the time of wrapping up. Dr. Kumar, you did not receive many questions. Give us your comments from what you picked from the question, the discussion, especially from what people are asking, and if you have any responses, Dr. Rem, from what he raised, and Antonia, and then you wrap up in 1 minute.
Yeah, thank you very much, Mark. I'd like we can't protect the Uganda Council at this moment. And that if there are any policies that come out that could actually affect the work which is going on at the plants that PCAU had, that would not be really good. So as a cancer society, what I'd like to say is that we're going to really keep our eyes on the ground and to look out for any policies from government or from other stakeholders that could actually our plan was concerned, and also the care which patients are receiving at UCI. And if anything actually comes up, then we can be there as civil society to really speak and advocate for the patient services that the expansion keeps on going on. I'd also like to mention that there is really a need for us to innovate at this time. Like Dr. Amanda said, COVID-19 is still here for a while. And very many of these restrictions, like transport, are really going to go on. So all of us involved in care, at facilities, in communities, we need to look for innovative ways of how we can actually continue delivering our services and ensuring that patients get that care with the quality that is actually needed. Things will not be as usual as care with the quality that is actually needed. Things will not be as usual for a while. So we need to really innovate how we can get to reach our patients and continue providing the services that are important. Transport is still a major problem, and UCS is going to continue working with PCAU to really try to get more support from the Ministry of Health. So that we can get more vehicle stickers and other support. And also PPE. The task force has really got a lot of PPE from donors and good well-wishers. And I think the fraternities of UCS and PCAU should work together to see how we can get onto the COVID-19 task force and really try to advocate for some of those things to come to palliative care providers and health workers who are providing care for us. So thank you very much, and those are my submissions.
Thank you so much. We will follow up with the key points from this meeting because we have notes and we'll share them with you, the speakers. For each one that the key points come up, and we will reach out to you, and then we'll get in touch with everybody. That's why we had to make sure that people register, and that's why we are encouraging everyone to become a PCAU member, such that you are on the mailing list for us to follow through. Antonia, kindly respond to any concerns that you received, and we will have Dr. Rem conclude. I don't see Dr. Monet online. We would have loved to have a Minister of Health speak to us. Florence Narta, I see your hand, but we have run short within a minute.
Thank you, Mark. One of the questions was about why we have stopped giving outreaches. It's really financial crisis as an organization. And also we were trying to comply with the presidential directives of avoiding gatherings. Someone from Fort Portal talked about that community aspect of meeting people in the community, doing home visits. But I think at this point, the Ministry of Health really needs to come up and support, because as NGOs, we do not have the finances to manage this. And if we shut down as organized NGOs, Ministry of Health will have to keep this going. Really ask Palliative Care Association to advocate more with Ministry of Health amid COVID and everything, and maybe for the future, that Ministry of Health owns palliative care in the nation. Then for the gentleman who wanted photos, I will have to look at the ethical issues, because the nurses who took photos in the gowns need to give consent first. They put them on Twitter. But we have made our local gowns using local material, just at least something to cover ourselves and protect the patients. And for nurses who understand, we can use the methods of barrier nursing. After use, you disinfect that gown and reuse, because we have made local material gowns and masks. So those are my two answers. I just ask for everyone to support NGOs doing palliative care wherever you can. And PCAU, we are looking to you to continue to advocate with the Ministry of Health on various fronts, because without Ministry of Health, palliative care is not possible. Thank you.
Innovative, and I hope in the next discussion we can talk about how appropriate it is for the innovativeness with PPEs, because I see a lot of it on WhatsApp groups, and what is supposed to be used, what exactly is appropriate at the community level, and what is appropriate at the health facility level as we are seeing patients. I think it's a great discussion that we should have, and since all of us are meeting patients at some point in time. And thank you for continuing to offer the services as well. We would have loved to have Ministry of Health. I have tried to search through, but we can't have. We would have loved to have Ministry of Health. I have tried to search through, but we can't have. We don't have Dr. Monet, but he had promised. But all of you know that he has been with us and he has been very supportive. And we really thank the Ministry of Health for all the efforts, because at least I see some people, I see the PRO and some people online. We for all the efforts. Because at least I see some people, I see the PRO and some people online. We are, and as you have heard from the people, from the providers, they are willing and ready to continue working with you when we reach out to them. I'm now going to request Dr. Rem, who has been gracious to us to give us all the time this morning, to give us concluding remarks. I can promise you that we are taking notes and we are going to come back to the action points and share them with the presenters of today and make sure that we relay whatever we think has come to follow up. And I call upon all of you to make sure that you are keeping in touch with us for the updates that are coming. Dr. Rem, kindly respond and give your concluding remarks.
Yeah, so thank you very much, Mark. I want to thank you, Forum, for today. I think every cloud, they say, has also some silver lining. And I think those are the kind of adage that I'll use in first responding to the issue that Dr. Mandwa raised. You know, it is amazing to realize Mandwa raised. You know, it is amazing to realize that actually a good number of the treatment that people have been getting from outside of the country, with this lockdown, they're getting it from here. And there is no issue coming about quality, no issue coming about availability, no issue coming about availability of drugs for treating cancer, no such things. And for those of you who have been in the system for a very long time, you imagine a situation a few years ago, when a thing like this happens, what would have happened? You would have had a lot of outcry from the cancer patients. I am yet to hear, I'm not saying that things have been done 100%, but I would say that we are rising to the occasion. The essential anti-cancers are available. Radiotherapy service is there. Investigations are there. Patients who are coming are getting that we have in this country to manage cancer. And I think that will greatly reduce the need for us to be referring patients to go abroad. Then number two, there are also innovations that we did not know before. Like for instance, our moving patients from here going back home. We had not known that actually, that how are we going to be sustaining this? These are the things that we need to keep on discussing about. It is a great need. It will improve on the compliance of our patients greatly. And then the third one is about telemedicine. You know, we are beginning to see that actually we can do a lot. We are beginning to see that actually we can do a lot remotely, be it via a telephone, be it via our internet, etc., in managing our patient. And we need to actually look at this very critically. And I'm happy to inform you that we are taking this up. We got some support from Uganda Communication Commission, and we want to make sure that we roll out telemedicine as a means of caring for our patient. Once again, thank you very much, Mark, and thank you, PCAU, for making this possible.
Thank you so much, Dr. Orem, and for giving us your time. And this has been very informative, and you are one of a kind because you always work hand in hand with the civil society. And because of that, I think that's why you are able to even do more with your team. Thank you for being approachable. Dr. Samuel Guma, the chair of the board of Uganda Cancer Society, we look forward to working with you even more on solving some of the challenges that have been mentioned. And of course, we will advocate and continue to appeal to the Ministry of Health. Thank you so much, Antonia, for being with us and for sharing with us.